Hi there. My name is Catherine Prince, and I am the Director of Rehabilitative and Exercise Therapies for Parkinson Wellness Recovery. I'm really excited to join you all today for our Ask the Expert event through Parkinson Wellness Recovery, because today we're going to be speaking about dystonia. So some of you may wonder, what is dystonia and do you have it? And if so, what do you do about it? And I'm hopeful that by the end of this talk, you'll be able to recognize some of those answers for those questions. Just a little bit about myself. I am a movement disorder specialist for physical therapy, so I specialize in working specifically with people with Parkinson's disease and dystonia, and my experience has been really focused on helping those with movement disorders. And if you've ever experienced rehabilitation for dystonia, that's fantastic. It is not as common, and so my hope today is to go through some of the basics of how diagnosis might occur and also how you might get treatment for a dystonia, or even if you think you might have it, what are the next steps? So I'm really happy to have you here, and let's get started. Today we're going to be going through what is dystonia and really talking about if you are a patient watching this or a person with Parkinson's watching this, how do you know if you do have it? And then also, dystonia can be impacted and felt in different ways. And so we're going to talk about how you might experience dystonia and whether it's dopamine specific or not. And then the meat and potatoes, talking about treatment ideas for dystonia and ways that you can actually make an impact on your symptoms of dystonia if you feel like you have them. And then lastly, we'll go over a question and answer, which may not be captured in this recording because that will be happening live. So traditionally, signs and symptoms of Parkinson's disease were considered to be mostly motor. And so the cardinal signs would be considered a resting tremor, akinesia or bradykinesia, rigidity, or postural instability. But now there are more non-motor and alternative motor symptoms that are linked to having Parkinson's disease. And we're realizing that there's more of an impact from those non-motor and alternative motor symptoms. And in that boat, we will be talking specifically about these types of symptoms here because dystonia is a motor symptom. So dystonia can be considered as a Parkinsonian symptom, and it actually can be found in people without Parkinson's disease as well. So it's not exclusive to people with Parkinson's disease, but it can be found in conjunction with people with Parkinson's disease as a movement disorder. It's actually more common than you would expect. So we're going to talk about how diagnosis happens, what it is, what it looks like, and what we can do about it. So first, let's talk about what is dystonia. It is not dyskinesia. It is a movement disorder, though. And again, this is something that can happen with people with Parkinson's disease, or it can happen exclusive of Parkinson's disease. So it's not necessarily that it always will happen in a person with Parkinsonism, but it is a neurologic disorder, and it causes excessive and involuntary muscle contractions. So those are usually kind of a sustained or repetitive pattern. It's always an abnormal muscle movement. So not necessarily something like a Charlie horse, if you will. Sometimes people will think that might be a dystonia, but more something that happens repetitively and creates an abnormal posture that lasts for longer than a moment. Usually it's over a period of time, and it actually may worsen or occur only with specific tasks. So you can have a task-specific dystonia, like a musician's dystonia or a writer's cramp, or you potentially could have a dystonia of a particular body part. But it can affect any body part, and that also includes how the muscles involved in speech and talking. So it could include eyelids, face, jaw, your neck, your vocal cords, torso, with a Pisa syndrome or camptocormia. It could be in the feet. But depending on the region of the body affected, dystonia may look quite different from person to person. And it is, because it is so unique, it can be sometimes hard to diagnose. Dystonia can be painful, and it can be like a cramping type movement, and it can also cause a twisting type feeling. So if you're experiencing any symptoms like that, talk with your doctor about it. If you notice that you're noticing these movements that are worse with stress or with fatigue, that also may be consistent with dystonia. So as that sympathetic nervous system ramps up and stress increases, then basically the dystonia can also increase, and those motor symptoms can increase even more so. And that also includes good stress, like a birthday party or something happy in your life, but anything that kind of gets the sympathetic nervous system, the heart rate increasing, then you may notice that that may increase those dystonic symptoms. And dystonia is actually the third most common movement disorder in the US. But one of the things that I always draw to people's attention is that there's a lot of diagnostic uncertainty, and we're not even quite sure what causes dystonia or why it's caused. And so that can make diagnosis really challenging. And one of the things that I always suggest is if you are considering the fact that you might have a dystonia or you have a client with dystonia, I would highly suggest having a movement disorder specialist take a look at them. Although it's very common, it is underdiagnosed, and that's partially because it is challenging to diagnose, but it's partially because we aren't quite sure of why it happens. Sometimes people don't even realize that they have it. So dystonic symptoms can also be really variable with time, which is why sometimes doctors may not see those symptoms. One valuable, hopefully valuable suggestion that I make for all of my clients with dystonia is if you think that you're having a repetitive patterned movement of contraction and you suspect that it might be related to dystonia, take your smartphone or have your family member or care partner take your smartphone and actually video record the symptoms when they happen. And that can give a lot of value to your medical practitioner so they can see what the movement looks like in times of stress versus without, or in times when that symptom starts to elevate, then you want to see it in real time. And much like taking your car to the repair shop and you're not hearing that noise that you took it there for in the first place, sometimes that happens with the symptoms of dystonia. And so it's a really good idea to capture it in real time on film if you have the technological capabilities to do so. It can be very, very helpful. So for the purposes of the talk today, I'm going to specify really what occurs in dystonia with Parkinsonism. So most of the time in PD, dystonia is more likely to occur in the limbs or the cervical spine, but it can occur anywhere. So just because it's more commonly found in those areas doesn't mean that it can't be found in another location. If you have multiple body parts that are dystonic, then it can indicate an atypical Parkinsonism. So again, that's another symptom that should be noted, and you should let your doctor know if that is the case. But basically, a dystonia can happen anywhere. And just keep in mind that just because somebody has Parkinson's doesn't mean they will have dystonia. And you can also have repetitive use dystonias. And a great example of that would be a runner's dystonia in the calf. So somebody who's repeatedly running, or contracting that calf muscle in the gastrocnemius can then lead to increased contraction in that gastrocnemius over and over and over again, even in times where they're not actively running. So it can occur throughout the body, and it's not volitional. It's not like somebody chose that posture. It's an active contraction that occurs throughout the day. And there are some syndromes like Pisa syndrome and camptocormia that are related to trunk dystonia, which isn't actually seen on this chart right here. But again, just keep in mind that for somebody with PD or PD specifically, they're more likely to have limb or cervical dystonia, maybe blepharospasm. And in this case, again, it can happen anywhere. Unfortunately, much like how Parkinson's is diagnosed, there is no formal test to test for and diagnose dystonia. So you can use EMG to distinguish the pattern of how the muscle fibers are contracting versus a normal muscle. And in fact, the movement disorder specialists who run maybe a Botox clinic for treatment options to reduce dystonia, they can use that EMG to actually guide where the muscle is most active, but it is invasive. So typically, a clinical diagnosis involves looking at that abnormal posture and looking at what is repetitive and predictable. It's going to be task specific, or it can be task specific, but not always. Typically, you'll have a sensory trick. And a sensory trick we'll talk about in just a moment, but a sensory trick is an activation of either an opposing muscle or even that dystonic muscle that helps to resolve the dystonia itself. So a good example would be somebody who has a head drop, an anterocollis, could put their hand underneath their chin to help to reduce that dystonia. And that's a great example of a sensory trick. Or somebody who has a head turn, or maybe a head drop, a torticollis with head turn and side bending, they can potentially put their hand on their head to reduce that posturing. So those are two good examples of a sensory trick. And so essentially it often includes some sort of sensory input with some sort of motor activation to help to resolve the dystonic posture, but it's not a permanent resolution of that dystonia. So doctors will also look at dopamine responsivity, because your treatment may be altered depending on if you're lacking in dopamine or if you have too much dopamine. And they may look at genetic testing as an option as well, particularly because there are some genetic components to dystonia that may lead to different treatment options or potentially a different prognosis. And there may be other neurologic testing to see if it's caused by some other impairment as well. Now we're going to take a look at what a sensory trick looks like and how it might be even used therapeutically in order to improve somebody's symptoms. So we'll take a look at this video here. And this particular gentleman has a dystonia with a dyskinesia, which often happens when somebody is reaching the peak of their medical level with dopamine, and what happens is they start to have a dystonia from too much dopamine in the system. So you'll see dyskinesia and dystonia. In this case, the individual uses their sensory trick by putting the hand behind the head and holding the head to avoid that downward head drop. So that actually provides opposing feedback in order to reduce dystonic symptoms. Now, he still has dyskinesia, which is that abnormal writhing movement that's occurring as he stands. The difference is that dyskinesia is caused by too much dopamine in the system, and it's essentially an overdose in the system, so it's causing uncontrollable movement. Dystonia can be controlled with those sensory tricks, so that's why you see extra movement there. Sometimes you might see a focal dystonia. And a focal dystonia is when only one body part or one small muscle group is impaired. So these tend to be very task specific. So in this case, this person's hand becomes dystonic when she was driving. So she wanted to demonstrate with gripping the wheel into flexion, she would start to have movement into her fourth and fifth digits. So in that case, then the pinky starts to extend. She started to get flexion in the fourth digit. And that's a really good example of a focal dystonia that doesn't affect multiple body parts. So again, those tend to be task specific, but not always, and they can be included with individuals with Parkinson's. Another example of focal dystonia that you might see out in public would be something like a runner's dystonia. And in fact, there was just an Olympic runner who just got diagnosed with a runner's dystonia recently. And as a result, she had to stop running because it would just trigger more and more and more provocative symptoms. Another more aggressive form of dystonia would be considered a Pisa syndrome. So clinically, that's something that is defined as lateral flexion of the trunk of more than 10 degrees in the standing position because of axial or spinal dystonia. And it can occur with the use of some anti-Parkinsonian drugs and antipsychotics as well. We don't know exactly why it happens. We don't know if it's reversible or not, but it's suggested that it can be, particularly if it's medication related. But if you notice that that lateral trunk flexion is happening, then the best thing you can do is treat it as early as possible. Now, in this individual's video, what you're going to see is that that right side of his trunk begins to almost collapse over towards the side. So we're doing balance testing, which is pretty provocative for this individual. And when in this posture, then he starts falling more and more and more into that lateral trunk control towards his right side. And that's ultimately where he loses his balance. So he was complaining of losing his balance while standing, and that's because that Pisa syndrome was worse as he would move. Sometimes you can have what's called an Anterocollis, or a forward flexion, or a head drop is sometimes what it's called, although that can be another name used for other disorders of the head. In this case, you'll see an individual whose head, literally the muscles in the front of the neck, are pulling her down. So she's trying to oppose those muscles with the muscles in the posterior, but it's very, very hard. And this was at a point where there wasn't a lot of treatment happening. So in this case, she can initially stop the dystonia and kind of fight against it using her oppositional muscles. But with more hold, more length of time, more fatigue, then that dystonia starts to trigger more. And then if you add walking to that mix, it's very challenging because that's a really dynamic task for people to do. To be able to coordinate your whole body and keep your head up with dystonia is very challenging. So this was a good example of an anterocollis, or forward bend of those muscles. One area that you might notice in people with Parkinson's is that dystonia of the foot can be more common, and that's often seen with a low dopamine level or perhaps with prolonged walking. In this video, you'll see an individual whose foot wants to plantar flex and invert, which is a really common form of dystonia in individuals with Parkinsonism. And you'll start to notice maybe some dragging of the foot or difficulty dorsiflexing or lifting the foot up against gravity with the muscles in the front of the foot. And it's very challenging, and you might actually notice if you do have dystonia in the bottom of the foot or the back of the ankle, you'll actually notice that the knee might lock as well, and that can be a really common sign when walking. And when that happens, I always envision possibly some foot or ankle dystonia. So it's important if you're noticing a foot slap, or perhaps you're noticing that your foot wants to turn inward or point down into the ground and it feels like you can't lift it up, that you speak with your doctor about it and kind of discuss some options for treatment, as it is pretty common with people with Parkinson's. Now we've gone through some of the symptoms that you might see and how it might be diagnosed, but one of the most common questions that I get is, what should I ask my doctor, or what should I ask my physical therapist or my occupational therapist or my speech therapist if I'm working on laryngeal dystonias or something like that? So I always recommend that you keep a diary of what the symptoms look like and what they feel like at different times of the day. And one of the reasons why I suggest this for somebody with Parkinson's is that if you may be dopamine responsive, that means when you are on or off your medication, you may notice a difference in your movement symptoms, and that also includes dystonia. So taking a look and being honest with yourself about when you may feel these contractions throughout the day gives the doctor a ton of information about treatment options. And also thinking about if positional changes or sensory tricks might be used. And as a physical therapist, I always want to know if that's the case, because if we can change it, we can kind of look at treatment options from a motor control perspective. Take note of how you feel. Are you having cramping? Is it painful? Are you having twisting? Is it certain movements in certain planes of movement? Or is it just, my foot points down and that's it? Or my finger flexes down and that's it? If that's the case, that might be information that the physician might want to know or your therapist might want to know. But also, if it involves multiple muscles or multiple joints, then the treatment might be a little bit more complex, or it might be different. We always want to know where it happens on the body, and if you're on or off your dopamine, and what time of day that's happening, and when you took your dose, and if you were even and regular about taking your dose on time. Always taking note of what makes it feel better. So does it feel better if you put pressure on it? Or if you lay down, do symptoms resolve? Do you use any sensory tricks to help to reduce those symptoms? And does it feel like it's in your control? So one of the things to note is that all of this information will give super valuable information for treatment options, but also for diagnosis from your physician and later from the therapist who may treat you. Once you've been diagnosed with dystonia, then there are treatment options. So the diagnosis, I like to think, is kind of the hard part, because it is a clinical diagnosis, and it is challenging for physicians to give an actual diagnosis. But the value is that there are a lot of options for treatment. I am obviously very biased because I'm a rehabilitation specialist, and I specialize in working with people with dystonia. So there is the rehab aspect of actually physically retraining that muscle group or groups in order to be better at motor control. There's also use of medications like dopamine or anticholinergics or benzodiazepines, and your doctor can work with you to try and figure out what are the best blend of medications that might help and also minimize your side effects in other realms. Botox is incredibly common. I used to work in a Botox clinic, and it's incredibly effective to be able to inhibit that muscle that is overactive. So it works better when there aren't as many muscles involved. But it doesn't mean that if you, let's say, have multiple muscles that are involved, that you shouldn't get Botox. It just means that you definitely should be seeing a rehabilitation specialist after the fact to make sure that you aren't getting compensations elsewhere because of the massive amount of Botox that's going in your system. So Botox tends to take about 4 to 7 days to take effect, and it does take about 2 to 4 weeks for a peak to occur for most people. And most people do experience a wearing off of around 12 weeks. And that's just because new muscle grows all the time. And at that time, new muscle cells are taking over. So what you once inhibited has now regrown back and may be still dystonic. Sometimes people can start to wear down on the amount of dystonia they take or the timing that they require it with training, with preparation to reduce, rehab and to be able to increase the motor control. And sometimes people need it like clockwork. So it really is very independent. It's dependent on the person itself. And then there are some new research-based frontiers, including non-invasive brain stimulation, that have shown some impact, especially in focal dystonias. As we speak about medication and its effect on PD-related dystonia, the vast majority of people who I've worked with personally who have Parkinson's with dystonia tend to be dopamine responsive. So if we consider that Parkinson's disease is a challenge, it's kind of a mixture between symptoms that are too inhibited, and that creates a decrease of symptoms, and symptoms that are disinhibited, and so you get too many symptoms like tremor. In that case, this dystonia would be a disinhibition. And in this case, your dopamine levels can really impact that. So this is where I go back to the idea of taking note of what time of day you're actually having these symptoms. So if you're having cramping or twisting or sustained contractions that really are happening at certain times of the day, it might be related to your dopamine levels. And it's really important to note if you're taking those medications on time as well, because the doctor may have calibrated it so that that peak and that lower kind of fit to when your dystonic symptoms occur. Not everybody who has dystonia is dopamine responsive. So just note that that doesn't make you abnormal. It just means that that treatment option might not be as effective for you if you are not responsive to your dopamine as it relates to your dystonia. And so then that means that alternative treatments like being able to use Botox would be much more important to utilize. If you are dopamine responsive, then here are some ideas for what the doctor may recommend for medication for treatment options. So this is merely for a reference. So don't take this to mean that these are the only options. I always say that medication dosing is an art, not a science. And that's because everybody responds to medication completely differently. And everybody who has dystonia and Parkinson's, they respond differently to their medication, and it may be different from day to day based on your exercise level, your sleep level, stress level, what you've eaten that day, a whole host of qualifiers there. So take this with a grain of salt. But if you're finding that you're having patterns of dystonia that are occurring, for example, in the early morning, then maybe that means that you're going to take a sudden increase of dopamine early in the morning. And that could be something like an injection of apomorphine or using an immediate release carbidopa levodopa. If you're having wearing off symptoms, so when your medication has peaked and then it's starting to go into an off period, then what they'll do is basically try to have an increased levodopa amount during that time frame. Or maybe the medication gets spaced closer together. Or maybe there are alternatives like COMTs or MAOB inhibitors that might help as well. And speaking of treatment, I am obviously very biased because I am a rehabilitation specialist, but I would highly recommend the idea of going to a rehabilitation specialist who's familiar with dystonia or movement disorders in order to reduce symptoms of dystonia. So much like the symptoms of Parkinson's, you will benefit from having task-specific training that is functional and related to those stressors that might trigger problems like freezing or festinating of gait. And with dystonia, that truth also exists. So basically, somebody who might have a dystonia that triggers with walking or perhaps with getting in and out of bed, or maybe it's occurring worse and worse and worse with fast movement, then the rehabilitation specialist has the ability to look at the motor aspects, sensory, autonomic dysfunction, so maybe that imbalance between sympathetic and parasympathetic nervous system activation, and then also social components and psychosocial components. So what can we do for education? What can we do for stress relief to be able to improve the sensory system so that the body is not as stressed during that period where dystonia is happening? We know that stress and increased sympathetic activation is not good for people with dystonia. So we want to prime the autonomic system for success. And we want to basically train the body to reduce the symptoms, but also first to reduce symptoms and activating symptoms of the dystonia, and then to start to gradually increase the challenge of the movement and the activity so that dystonia doesn't happen. So you usually start by inhibiting the dystonia and finding those patterns and postures and positions that help. And then you gradually increase the challenge and start to go to more challenging postures and positions and gradually provoke the dystonia so that you can see, okay, how far can I push this without that dystonia becoming a problem? So in this particular treatment wheel, this is adapted from Julie Hirschberg at Reactive in California, and so they do a lot of work with people with dystonia, and this is based on a talk that we gave at Combined Sections meeting for the American Physical Therapy Association. But this treatment wheel is dependent on the person. So somebody might have a ton of autonomic symptoms that feed into their dystonia, but they may not have as many challenges with motor control impairments, or maybe they don't have as many physical limitations, or maybe you have somebody who has a ton more sensory impairments and they need that sensory input and sensory retraining to be able to say, okay, my hand is in this position, and when I move it, this is the position it goes into, and this is how I will rotate it, and these are the muscles that I will engage. And so every person is different. But all of these treatment options are ideas that have been evidence-based or evidence-informed to support people with dystonia, and not necessarily just in Parkinson's, but also in other forms of dystonia as well, because a lot of the research that's supportive of people actually doing rehabilitation with people with dystonia is really targeted towards focal dystonia, because it's more common and it's a little bit easier to analyze and treat, because it is so on a smaller scale throughout the body. But just keep in mind that all of these options are things that can be tried. Again, the whole goal with dystonia is to essentially reduce the movement and aim for error-free movement in a way that you can figure out what the triggers are and reduce the triggers and improve the motor control when you have those triggers, and to basically be able to do harder and harder graded exercise. So really focusing on being able to use the whole body and the whole sensory system, the motor system, the psychosocial components, being able to use your autonomic system to work for you. So again, I highly recommend, if you haven't experienced going to a rehabilitation specialist, please do, because it can be of huge advantage. And I just wanted to thank everybody for coming out today and watching this talk. And so obviously the question and answer is actually happening live and not in this recording, but I encourage anybody who might be interested in working with a physical therapist, specifically for their dystonia, or if you have additional questions, you can contact us at Parkinson Wellness Recovery. And I've listed that phone number below, or you can contact us at info@PWR, the number 4, life.org. In addition to that, if you would like to attend our next wellness series, please check out exerciseforbrainchange.org, because at that website, you'll be able to see when our new wellness series is occurring. And we do offer them monthly, so we would love for you to be able to attend. And just know that we will be putting those online as well. So after they're recorded, assuming they are recorded, we'll post them online so that people have access. But we really appreciate you coming, and I hope you gain some valuable insight about dystonia, and specifically dystonia with Parkinson's. Thank you so much.